Thank you so much, and thank you for being here with us this morning. I wanted to give a little bit of an overview of this situation before introducing our esteemed panelists. From 1999 to 2014, more than 165,000 people in the United States died from overdoses related to opioid pain medication. In 2012, healthcare providers wrote 259 million prescriptions for opioid pain medication. That's enough for every adult in the United States to have their own bottle of pills. When you look at prescription opioid and heroin overdoses, the picture is even more grim. When you put those two together, there were more than 28,000 deaths due to overdoses of those drugs in 2014. This epidemic is unprecedented and requires powerful strategies on many levels. So here with me today are two gentlemen who will talk about the approach that the federal government is taking. To my right, Dr. Vivek Murthy is the Surgeon General, the U.S. Surgeon General, just in case anyone was confused, the U.S. Surgeon General. And Tom Vilsack is the U.S. Secretary of Agriculture. And in January of this year, President Obama appointed him to lead an interagency task force to combat the epidemic in rural America. So for both of you, let's start with an overview and just sort of for your thoughts on this issue in general. Do you want to go ahead?
You bet. Well, I also want to thank you all for being involved and being interested in this issue, and want to thank the Surgeon General for his incredible leadership. And I would be remiss if I did not point out a distinguished person in this audience, which is former Governor of Kentucky, Steve Beshear. That's why Pat are with us, or Jane with us today. Governor Beshear was a great leader in extending access to health care in Kentucky, and particularly in rural areas through the Affordable Care Act, and that is part of the solution that we're going to talk about today. You may wonder whether or not I had taken the wrong route on one of the trails here and ended up at this conference. You wouldn't think the Secretary of Agriculture would be somebody that would be part of a conference like this. But we at USDA are investing hundreds of millions of dollars in expanding access to mental health clinics and treatment opportunities in rural areas. 76% of the shortage areas that exist in treatment of substance use disorders or mental health occur in rural areas. The rate of opioid abuse in the United States is at a higher rate in rural centers than in urban areas. And in fact, the suicide rate is twice the rate it is in urban and suburban areas. So it's a serious issue for people in rural areas, in part because of the work that we do in rural areas. It leads our folks to have more physical challenges and pain from time to time. It's more physical. We are remote, and oftentimes because of that, there is the attitude of, I'm going to get through this. I don't need to admit that I've got a problem. I don't want anyone to know I have a problem. And so it's important to get the community engaged in making sure that people understand this is a disease. It's not a character fault, and encouraging folks to seek treatment. And I think what we'll learn today is that one of the secrets is not only focusing on better prescribing regimes as the CDC has proposed, but also focusing on how we might be able to expand access to treatment. And I'm particularly interested in doing this in rural areas, and I think the Surgeon General and I will probably talk about the need for additional resources behind this effort. We've had grants recently to expand access to treatment, but the reality is that this problem is massive, and it's really going to require a national, significant commitment of resources.
Thank you.
Well, first, I just want to say thank you to all of you for being here, for being interested in this topic. I believe that the prescription opioid epidemic that we're facing in America is one of the most critical public health challenges that we face. And you might ask, well, why is that, and how did this actually happen? Well, I think we actually got here relatively quickly, but on a path that was paved with good intentions. About 20 years ago or so, clinicians, doctors, nurses, and others were urged to be more aggressive about how they treated pain. But they were urged to do so without being given adequate training and support to know how to treat pain safely and effectively. And that coincided with the heavy marketing of opioid medications to doctors. When you put all of that together, you have, unfortunately, the epidemic that we see today. You have a quadrupling of overdose deaths since 1999 that actually tracks with the quadrupling of the quantity of opioids prescribed since 1999. We have about nearly 2 million people in America who are now addicted to prescription opioids. And we see that it's not just about prescription opioids, but this epidemic is contributing to the use of heroin and to the spread of hepatitis C and to HIV. Now, we can think about the cost of this in two ways. We can think about the financial costs, and there it's hard to underscore just how massive that is, because it's not just about healthcare costs. Those are big enough. This is also about lost productivity. This is also about people overdosing and dying, and all of us collectively as a society losing people who could have been productive, contributing members of society. But there's a humanitarian cost here, which is also massive, which is the pain that's caused to individuals, to families, and to communities. I've seen this epidemic tear communities apart, tear families apart. I saw it initially as a doctor practicing medicine in Boston, where I met many patients who would come in for pneumonia or for a leg infection or for an issue related to their heart. But in the background was an issue around substance use, which sometimes we appreciated and sometimes we didn't. But what I quickly came to see is that when we don't address the addiction issues in the background, it makes it hard to take care of all the other issues. Simple example, somebody comes in with heart failure to the hospital. This happened so many times to me and my colleagues. We would spend so much time trying to adjust their blood pressure medicines, use the best evidence possible to make sure they're diuretic medicines, which make them, basically urinate fluid to get it out of their body, make sure that those medicines were titrated just perfectly. And all the work we put into it was fine, but if we didn't take care of their substance use disorder in the background, if they had severe untreated issues around addiction, their likelihood of taking those medicines, of following up with the doctor, of calling for help when they need it was dramatically lowered. So this is an epidemic that isn't just about prescription opioids. It touches so many elements of our lives. And that's why Secretary Vilsack and I and so many others in the administration have made this a key priority. It's why President Obama has made this one of his top priorities. And it's why not just the Department of Health and Human Services, but Secretary Vilsack and his department and many other agencies in the federal government are working to see what they can do to address the epidemic. And in particular, we're all collectively working to sharpen prescribing practices so that we make sure we're getting opioids to people who need it, but reducing the number of inappropriate prescriptions. We're making sure that we get naloxone, which is a medicine that reverses overdoses, into the hands of first responders. We're also making sure that we expand treatment, and as we'll talk about later, funding is incredibly important for that. But the last point I want to make is not actually about a policy, it's about a cultural change that we have to make, which is that we have to change how our country sees addiction. For far too many people that I meet on the road, they are living with substance use disorders but are scared to come forward and ask for help because they worry about the stigma that's still associated with this illness. I was just in Tennessee as part of an opioids tour that we launched a few weeks ago. And usually when I do the tour, we talk to folks who are living with addiction. We give them a chance to talk to the media as well so they can tell their story. In Tennessee, there's nobody who wanted to come forward and talk to the media because they were so scared that if their boss saw them on TV, that they would get fired. If their friends or neighbors saw them, that they would be stigmatized and maybe even run out of their neighborhood. So we have to change that. We have to help our country see that addiction is not a character flaw or a moral failing. It's a chronic illness. It's a disease of the brain, and we have to treat it with the same skill, urgency, and compassion that we would treat diabetes, a heart disease, or cancer.
So Dr. Murthy, when you were in training and in your early days of practicing, what attitudes and practices did you see around prescribing opioids?
Well, it was interesting. I think there were a couple of things that now are very striking to me looking back. One is that when we were not really given a whole lot of training in how to deal with pain and how to really assess whether there was a risk of addiction present. In fact, many of us were taught that opioids were not addictive as long as you give them to somebody who has legitimate pain. Now, that seems almost laughable in retrospect, but I'll tell you that just a few months ago, I was in Florida for an event, and I met up with an old friend who's a cardiologist. He's trained at some of the best institutions in the country. He's one of the most compassionate doctors that you'll meet. And I was having dinner with him, and I said, can you believe that we were taught that these opioid medications weren't addictive in our training? And he put down his fork, and he looked up at me, and he said, wait, you mean they are addictive? Like he didn't know. And this is really striking, but my point in sharing that story is that there are still prescribers out there who haven't realized the full impact of the decisions they make about prescribing opioid medications for pain. So that was one thing that's striking to me. But the other thing that strikes me about our training is how we were taught to look at addiction. And nobody ever put in a curriculum that addiction is a character flaw, that only bad people get addicted to medicines. It was never written anywhere. But it was the unsaid message that came through when we would sit with senior doctors and discuss cases, and people would lament that, oh, there's this person who's an addict who's coming in again for the 4th time this month, and they would speak ill, of that person, but they wouldn't do so of the person who came in for the 4th time with heart failure, or the person who came in with the 4th time with an asthma exacerbation. And so those kind of cues are incredibly important in medical training, because trainees, they take their cues from their senior doctors. And that's why, as I go and talk to doctors around the country now, I tell them that we have an incredibly important role, not just in changing our prescribing practices, but in modeling the kind of attitudes that we need to have toward substance use disorders, modeling that can not only impact our trainees, but that can impact other people in the community.
And Secretary Vilsack, you come at this issue with a very personal background and story. Can you talk about that?
When the general was talking about the doctors and their attitudes about prescription drugs, I couldn't help but think about my mom. I was adopted into a family where my mom struggled in my early life with prescription drug addiction and alcoholism. And it was something that was the kind of thing that we did not want anybody to know. As a young person, it was my feeling that my mother was weak, that she could overcome this, that she could just make a decision not to drink and not to take these pills. I didn't know, didn't understand, didn't appreciate that this was an addiction. Fortunately for her, and fortunately for our family, on Christmas Day, 1963, she made the decision to do something. She had tried taking her life several times. She had reached that point where she was going to go down one of two roads. She looked to her faith, and most importantly, at that point in time, there was somebody to help. She had a long-term treatment plan that she went into. There was a community that she came back to that was supportive. She had AA meetings, she had sponsors, she had people she could talk to on a regular basis. She had a family that ultimately began to trust her and believe in her. And she taught me a valuable lesson. One, not to give up on someone that you love and something that you care about. And two, not to make a judgment that this is in fact a disease. It is in fact something that is incredibly difficult for the individual and the family. That's why it's so important and why I'm interested in rural areas. When that person in rural America reaches the point that my mother reached, how frustrating will it be if that individual turns around seeking help and it's not there because they happen to live in a rural community?
I want to follow up on that, but I wanted to ask you another question first, which is when you meet people who are struggling with addiction, what do you say to them to try to help remove that feeling of stigma, to help remove that shame? What do you say to them?
Well, I give them the example of my mom and the fact that I've learned and that they need to understand that there are many people willing to help, that they cannot and should not feel that they have to do this by themselves, that this is not a test of character. This is essentially getting you in the right place with the right people, focused on a plan, a long-term plan, a day-by-day plan to lead you to a better life, and that it is incredibly possible if you have the treatment, if you have a community that is supportive of you when you get out of that treatment facility. The challenge we have now, and I think the Surgeon General would agree, we have treatment facilities, but sometimes it's not something you can do in a couple weeks or a month. It may take a longer period of time, and that gets back to societal judgment and whether or not we're willing to provide the resources to make sure that those people who need long-term concentrated effort are able to get it and secure it. One of the good things about the Affordable Care Act is that we're now beginning to change the way in which we reimburse and pay for these services, whereas before it was treated as something separate and distinct from cancer or heart disease. Now we're supposed to be looking at these treatments in the same way, and hopefully that opens up opportunities that didn't exist before.
Because when people do finally decide that they're going to seek help, they often face a long wait.
They often face a long way, oftentimes fail multiple times, and we have to be patient, and we have to continue to be with them and stick with them. And this problem is getting larger. I mean, we now have 2 million folks, as the general indicated. There was an NIH study that just came out that said that 4 million Americans have admitted to misusing opioids. And now, according to the Kaiser Foundation, 44% of Americans know someone This is an issue that's so broad that you cannot, in this room today, I'm pretty sure by raising a hand, we could find virtually everyone who knows someone close to them that is challenged with or dealing with this. So it is pervasive. And again, put yourself in the position of someone in a rural community where there are no mental health services, there are no professionals. There is not the opportunity to come out and say, hey, I've got a problem without people being judging you. Your job is at risk. How much harder it is in those rural, remote areas. And that's why it's important and necessary for us to make a commitment, not just in urban and suburban areas, but also to include rural areas.
And Dr. Murthy, what can we do about those long waits?
Well, it's a good question, and I think Secretary Vilsack brought up something that I want to expand on a little bit because I think it's incredibly important, which is about what the nature of addiction is, and this gets into what kind of treatment we need. Addiction is not like, it's not like pneumonia, where you go in and you take a medicine for 7 days and then you recover and you get better. This is a chronic condition. And when you think about the steps that somebody has to take to ultimately get from where they are to a place of recovery, that requires, one, having health insurance coverage, which is why the ACA has been incredibly important. It's why Medicaid expansion is incredibly important. It's why Governor Beshear's work in Kentucky is so helpful and essential for addressing this epidemic. It also requires that they have the courage and the support to go and seek treatment. Because if it's there, but I feel that there's so much stigma and I don't want to be judged and I don't want to be seen walking through the doors of a treatment clinic, then I'm not going to do it. The third thing it requires are providers who are trained in how to provide care. And when you provide medication-assisted treatment, which is the evidence-based approach for treating addiction, that's a combination of medicines, it's a combination of counseling, it's a combination of social support services as well. So you have to have all of those that are included. And then on top of that, you need a personal network of support that the person can rely on. Because like the secretary was saying, this is a condition where people often end up having to take several swings, at the ball, so to speak. They have to go to treatment multiple times because sometimes they relapse. And those are very difficult moments. And those are made much harder when you don't have a network of social support. So if you think about all of these factors, you realize that treating substance use disorders is complex. And one of the things that does make it complex is that we have a massive treatment gap right now, even in treatment centers. So right now we have about 2.2 million people who need treatment for prescription opioid addiction. Only about 1 million of them are getting treatment. And that's why it's so important that we invest in expanding our investment in treatment. And the last point I'll say on this is that if we understand the nature of addiction and what it takes to get out of it, it will be much easier for us to build public support for that investment that's so important. Right now the president has requested about $1.1 billion in additional money to fight the opioid epidemic. That's money that will go toward expanding treatment in addition to getting naloxone in the hands of first responders and helping us improve prescribing practices. But right now Congress hasn't yet given that money, and so we're still waiting for the opportunity to expand treatment. But all of this is made much easier when the public understands, one, how important this is, but also what's required. Because addiction really is it's a disease that impacts your brain in profound ways, in ways that in fact alter your judgment. And that's what's so important for people to realize. Because sometimes people say, well, it's just a self-control issue. If they just had more willpower, then they would choose not to take the pill again or to inject heroin. But the truth is, this is a disease that in fact takes a toll on your ability to make good judgments. When I was in Arizona, actually, just last week, there's a young man I met who told me that he felt he never fit in high school, and he got into prescription opioid drugs because that was the first time he felt actually good about himself, is when he was on a euphoric high after taking opioids. A few years later, he was diagnosed with testicular cancer, went through a horrendous experience, but came out on the other end and was ultimately told after a long course of treatment that he was in remission. But a few years after that, the doctors called him and they said, we have bad news for you. The cancer is back. Now, if any of you had the experience of going to a doctor and being told that you had recurrent cancer, you'd probably be sad, right? He was elated. The reason he was elated is because he felt that he would likely need a major surgery and that would be an opportunity to get more prescription opioid medications. He shared this with me to illustrate just how profound the impact that addiction can have on your judgment. So this is important for us to understand. If we understand the nature of addiction, it makes it easier for us to stop judging and to start helping. And that's ultimately what we have to do.
Can I pile on that point? There is a criminal justice aspect of this. When you talk about judgments, I was in New Hampshire recently, and a young man who was 35 years old who had a 32-page rap sheet. At age 15, he was turned on to prescription drugs and heroin by his father, who was also an addict. He finally found his way into a drug court, into a system that was designed not to punish him, but to try to help. So you can see, as these young people get access to these drugs, in addition to the challenges that any young person has in terms of making the right judgments, it takes you down a path. And if we begin to think we can incarcerate ourselves out of this problem, we were headed down the wrong road. We would be much better off taking some of those resources that we're currently using to build prisons and jails and redirecting them into the kind of treatment facilities that the Surgeon General is talking about. So this judgment issue is a really important one.
The drug courts are an interesting point. Are they widespread? Can you talk a little bit, first of all, about what they are in case for people who don't know, and how widespread are they? How common are they?
So an individual is arrested basically for a drug-related offense. Maybe they're stealing something in order to pay for the drugs or heroin, as many people sort of migrate into heroin use from opioids. Decision is made that this person might be benefited from a more aggressive treatment effort as opposed to incarceration. So they are given a parole officer, they are given a case manager, they are given access to treatment, they are given a psychologist or psychiatrist who can provide help and assistance, they're given a social worker. They're, in other words, given a community of support that surrounds them. Part of the challenge is finding a place for these folks to live. That's why USDA comes into play. We have housing programs at USDA, so we're now looking at creative ways to use our housing programs to create an opportunity for them to be able to live in decent housing. They get counseling, they get treatment, they get a job, they get education, they get training. Incredibly successful in terms of helping people. This young man's life has been totally turned around. He is a disciple and apostle for all of drug courts, but they are challenged. They are not as widespread as they need to be. They are expensive. That's why it's important for us to figure out ways to redirect resources that are going into systems that punish as opposed to systems that will help treat and hopefully put people on the road to recovery. And I think it gets back to the attitude. You know, we had over 28,000 people die from heroin and opioid abuse last year. 28,000. That's more people than died from car accidents. If you think about the reaction that society had to automobile safety and all of the steps that have been taken by the auto industry, by the government to try to provide protection and assistance, and the difference that that has made, the lives that have been saved, less serious injuries as a result of seatbelts and so forth. When you think back at the initial reaction of the public to wearing seatbelts and so forth, now it is just absolutely common practice. The reality is that kind of mind shift has to take place on addiction, and I think if it does, then you'll begin to see significant redirection of resources. That's why these forums are important, because the leaders in this room have the capacity to use your voice back wherever you come from and whatever leadership position you have to articulate the need for a different attitude. And I think that attitude will drive a lot of decision making. Congress right now is, as the Surgeon General indicated, is taking action, but what they are doing is simply authorizing certain actions. They're essentially giving permission for the Surgeon General and for the Secretary of Agriculture to do what we're already doing. Without resources, it is not going to be particularly effective. So it is important, I think, for people to understand that this does require some investment.
Speaking of resources, no one would say that the pharmaceutical companies got us into this mess, but it is indeed their products that are being abused, and there is a history of actual criminal findings where people were misled, where misleading data was put out there. Can and should the government go to pharmaceutical companies and say, hey, can you give us some money, this is expensive, to fix this problem?
Well, you know, you're absolutely right that there was a role that pharma played. Then when we look back on this problem and do the autopsy, if you will, on how we got here, we see that there were many players that were involved in getting us to where we are today. And to me, what that means is that all of us then have a responsibility to help us get out of this problem and to fashion solutions. And that includes the pharmaceutical industry. I know that there are pharmaceutical companies that are working on abuse deterrent formulations of medications. For example, prescription opioids that can't be crushed, so that they can't be then injected. And that's good, to have, I mean, there's more work that has to be done in that area. I would personally like to see pharmaceutical companies get even more involved in helping support treatment and helping to work with prescribers to actually sharpen and improve prescribing practices so that we are treating pain safely and responsibly. So I do think there's a role for pharma. I think it could be bigger. I think it needs to be bigger. But I do also want to say that, it's important for us to also recognize that, like I said, that everyone does have a role. So if you're not a pharma company, you're not a doctor, you're not somebody whose family member is living with addiction, that doesn't mean that you can't also help as well. And I want to be very clear on that, because we know, for example, that that attitudes are often impacted by, like my attitude is impacted by the people who are close to me, by my parents, by my wife, by my close friends, by my colleagues at work. That means each of you has the ability to impact how other people think about issues around substance use. It means also that you can give people permission to talk about these issues. So many people are actually suffering in the shadows. They know that there are probably others out there who are having similar issues. They don't know who they are, and they don't want to be the one who raises their hand and says, hey, I need help. But in your own way, using your own voice, within your own social circles, you can help create ripples that will change the way our country sees addiction. And that's incredibly powerful, because I can't emphasize enough what the domino effect that happens when thinking changes on the ground. And if you look at, for example, the gay rights movement in our country, right? We very quickly went from a place where we denied rights and to folks who were LGBT to a place where more and more people recognize that we should be treating our brothers and sisters in the LGBT community with the same respect, with the same rights that we would anyone else. And what facilitated that, in part, was a major shift in attitudes in the community. And that's going to be important in fighting this epidemic as well.
So Dr. Murthy mentions pharmaceutical companies spending money on new formulations, et cetera. But how about just good old-fashioned cash? These programs are very expensive. This program is gigantic and is probably going to get worse before it gets better. What do you think of that idea?
Well, I think basically it's a partnership. We see in other aspects of government a public-private partnership working well to leverage government resources and private sector resources. So there's no reason why that model could not be used in this context. I think it is important for the pharmaceutical industry, for its own well-being, its own self-interest, to basically be engaged in this debate, to help us spread that message of attitude adjustment and a change in attitude. And I think in the long run they will be better off for it. I think there are ways, if Congress were to pass additional resources, they could direct departments to essentially use those resources in a leveraged way. We've done this, interestingly enough, in conservation and natural resources. Well, here we're talking about conserving lives. Well, why not basically say, here's money, but one of the conditions of using the money is that you have public-private partnerships, that you reach out to state governments, you reach out to local governments, you reach out to nonprofits and the private sector, the for-profit companies, and basically get them involved. Because at the end of the day, these are our workers, these are our families. It's reducing unnecessary healthcare costs. It's reducing the overcrowding conditions in prisons. I mean, there is a whole host of ways in which we all get impacted by this. If there is a young person in a school that is addicted, that person may be disrupting an entire classroom of young people trying to learn. So we are all connected to this in one form or another. So it seems to me that we all ought to be connected in trying to arrange for the type of society that makes treatment available.
How expensive will it be to solve this problem? I mean, considering the huge number of people who need to get into treatment doesn't always work the first time. How expensive will this be?
Well, right now we have about 1,000 centers in the country today that address behavioral disorders in one form or another. Unfortunately, only about 25 of those are located in rural areas. So when you think of the general landmass and the number of small communities that there are in America, you can see that it is an expensive proposition. Now, not every single community has to have a brick and mortar facility. What we do at USDA, we use our broadband efforts to try to bring the experts from faraway places to the local community, but not actually physically there. We use telemedicine. That's an opportunity, but all of that costs resources. The president's budget, I think, wisely proposes additional money, roughly $920 million, to expand access to treatment facilities. Now, you want to do it right, and you want to do it in places that are ready for that opportunity. But that's a 2-year period, so you know that's just beginning to scratch the surface. Then there's the issue of professionals. I mean, the reality is the president's budget also proposes additional money to train and to encourage more people to get in the National Health Service Corps and provide access to professionals. But you know, it's very expensive to get that degree, that medical degree. So we have to think of creative ways to encourage more people to get into that line of work and make them available in rural areas. I don't know that anybody's put a price tag on this, but I can tell you what it's costing us. In addition to the 28,628 folks who died and the families that have been impacted, the 2 million that are currently abusing, it's $25 billion of unnecessary healthcare costs. It's another $25 billion or more of lost productivity, and it's $5 billion of criminal justice costs. So if you took a portion of those resources and redirected them, you could go a long way to helping a lot of people, and a change of attitude, I think, would help leverage those resources to the point where we'd be on the other side of this problem.
Let's talk a bit about what we've seen work so far. You mentioned the drug courts, that those have been effective. Any other programs, either federally or in individual states, that have shown some promise?
Well, I think there's actually a lot that's working, and that's actually, it's important to point out because there are many bright spots in this epidemic that we can look to. I think the drug courts are absolutely one, and I think if you, in addition, if you look at treatment centers, I've spent the last few weeks actually visiting a series of treatment centers around the country, and I can tell you that the people who work in these medication-assisted treatment centers, you know, you might think, well, they have some of the hardest jobs in the world, but they often tell me how lucky they feel to be working there, because it's incredibly gratifying, they say, to be able to provide people who have struggled with addiction for years the treatment that they need. And many people who they treat will tell them that it was only when they got treatment that they felt like they finally got their minds back and that they finally got their lives back. So I think we do have examples of successful treatment centers around the country. We also have examples of using technology in ways that are improving prescribing practices. Some of you may have heard of prescription drug monitoring programs. These are tools that allow doctors and nurse practitioners, dentists, and PAs, physician assistants, to actually get more information about the patient who's in front of them before they prescribe an opioid pain medication. For example, many of us who have been in that situation where we were trying to decide whether or not to prescribe a pain medication to a patient have asked ourselves the question in the back of our head, is this patient getting medicines from other people? Am I like the fifth stop, you know, on the way to actually getting a large dose of opioids? Or do they have genuine pain, and do they need, am I the first person they've seen, and are they relying on me entirely for their treatment? And you know, you want to assume the best, you know, about people, but knowing that addiction is an illness that can impact your judgment, we also want to check so that we know when to give opioids and when not to. This system, the prescription drug monitoring program, is now present in many of our states, in fact, nearly all of our states. And it's a tool that can help prescribers understand if the person who's sitting in front of them is at a high risk for addiction, and if they've been getting opioid medications from other prescribers. And if they have, then that would make you think twice or thrice or 4 times before you prescribe medicines. And in fact, it may make you more likely to look for signs of a substance use disorder and try to connect that person in treatment. So there's a lot that's working, but the key thing that we have to do now is scale a lot of this up. And we have to make sure that more people are involved in the solution. It's part of the reason why the campaign that my office has launched is actually focused in particular on prescribers. And so in addition to going and visiting prescribers around the community and talking to them about the importance of getting involved in turning the tide on this epidemic, next month I'll also be sending a letter to 2.3 million healthcare practitioners, including all the folks who are licensed to prescribe opioids in this country. And we'll also be including in that a pocket card that clinicians can keep in their white coats and reference when they have a patient who has pain and when they're trying to make difficult decisions around treatment. So there's a lot that's working, but we have to scale it up. That's why investment is so important.
Anybody in this audience from Missouri, by chance? Wow. The reason I ask about Missouri is it's the only state in the country that doesn't have a monitoring system. And it's a result of one politician, one state senator, who blocks every effort to try to get a monitoring program in place. And so we're...
Why would he do that?
Well, he's concerned about privacy, which, honestly, there are ways to deal with the privacy issue. That I think it's I don't think it's a legitimate reason, but that is his reason, and he has been successful up to this point. Legislation has passed the House. Now, why is this important? Well, if you look at a map and you look at the states that surround Missouri, well, if you are in Iowa or Illinois or Nebraska or wherever, if you don't have a monitoring system, then your monitoring system in that particular state may not be particularly effective because there is no counterpart over in Missouri, so people can just hop over the state line. So it is really important for these monitoring systems not only to have them, but also to have them be able to communicate across state lines, which we're now in the process of encouraging governors to do, and also to essentially make sure people actually use the monitoring system and input data in a timely way. One of the things that's working, I think, and we'll see more of it, is this effort to train physicians. The medical societies have come together and they've decided to set as a goal 525,000 physicians who will be trained in terms of appropriate medication processes and guidelines. They've trained about 75,000, so they're on their way to getting better training. The fact that medical schools, nursing schools, pharmaceutical schools are basically now changing their curriculum is incredibly important, and that is going to work. And I think, frankly, what's also part of the solution is engaging our faith-based community in creating that space for people to be able to talk about this.
Dr. Murthy, I'm going to put you on the spot just a little bit here, which is that aside from...
Story of my life.
Okay. Aside from cancer care or palliative, end-of-life palliative care, is there ever a reason for someone to be taking these drugs long-term? Short-term, I think there's agreement, 3 days after back surgery or whatever, but is there any legitimate reason why for people to be taking these opioid drugs long-term?
Well, so this is a good question because one of the big concerns that community members have around this whole campaign that we're engaged in to tackle the opioid epidemic is they worry that we're going to take opioids away from people who really need them. And the truth is that there are many people who have been on opioids for years for chronic pain and who feel that it is actually helping them. So having those conversations is challenging, but it's incredibly important. And so what we do know, though, if we look at the science and the data, is that the vast majority of people who have chronic pain do not need opioids. Now, let me be clear about what I mean by that. I'm not saying that opioids don't make them feel better, but what I'm saying is that the ultimate impact on their health tends to be more negative than positive. And why is that? Well, it's that number one, your body builds up tolerance to opioids very quickly, and you find that if you have somebody on opioids for weeks and months, you end up having to escalate the doses fairly quickly, especially in the beginning of treatment, because the body just gets used to it. The second issue is that you can actually paradoxically develop something called a hyperalgesic effect with opioids, which is that when you're on them for a while, they can actually sensitize you even more to pain. And the third thing for us to keep in mind is that opioids, they create a euphoria. They make people feel better. They treat pain, but all kinds of pain. Right? So some people will tell us that they find that the opioids not only help for their back pain, but they help to calm their anxiety, that they help in other ways. And so what we find is that we think we're doing something fairly benign and something that's helpful, which is giving someone a medication for their pain. But when we keep them on it for a long time, these negative effects tend to build up, and we actually put them at risk for addiction and also for overdose. Because keep in mind, the higher your dose, the greater your risk for an overdose. And the majority of deaths that we're seeing are not intentional deaths, where people are intentionally taking a large amount of opioids in hopes of passing out. These are unintentional overdoses, people who think they're taking a safe amount, but it's so high that it's actually hard to keep them safe. So this is why that's why this is a complex issue, because we have to be, I think, thoughtful about how we have this conversation with the community about the fact that opioids for chronic pain, with only a few exceptions, being cancer-related pain, end-of-life palliative care, that this is actually not the best treatment for chronic pain. On the flip side, there are other treatments for pain that we have to know about. So one is we know that physical therapy can actually be incredibly helpful and important for treating pain. We know that cognitive behavioral therapy can be useful. We know that we have a limited number of non-opioid medications that can treat pain, but they are effective. And we know that the more research we do, that we're starting to realize that there are other tools. that could be investigated and could be potential assets as well when treating pain, like massage, like acupuncture and others. Now, if we really want to build out that toolbox so that we have a large set of non-opioid tools to treat pain, then we have to invest in research and understanding more about what works and what doesn't work, in the R&D to actually develop new non-opioid medications that can treat pain. That's, again, why the investment piece is so important. So this is a complex issue, and this is actually why it's training doctors in how to prevent this epidemic is so important, but also so challenging.
So if those patients were your patients and they said to you, oh, doctor, it helps me so much. I know I've been on it for several years, but it helps my back pain. They're great. I want to stay on them. What would you tell them?
And this is it's not a hypothetical. I've had many patients like this. And the toughest ones, I'd say the toughest cases, are when a patient has been seeing another healthcare provider for years. And they come to you and they say, you know, I fell, I was in a motor vehicle accident, had a back injury 5 years ago, and my doctor in, let's say, New Hampshire has had me on oxycodone for the last 5 years. I just moved down to Boston, and I'm seeing you for the first time. Can you renew my prescription? And if you don't renew it, then a patient with the best of intentions might think, well, you're not providing good care. I had a good doctor there. Why aren't you providing good care? They might think you don't care about my pain. Why don't you care about the fact that I'm suffering? And so what I do, like in those situations, is one, I try to get a sense of the pain and their functional status. The reason I mention the functional status is what we have begun to realize more and more is that our goal in treating pain should not just be to get pain to zero, but in fact, even more importantly, it should be to improve someone's function. And that means, like, are they able to play with their kids the way they want to? Are they able to do their work? Are they able to walk around the house and just do that normal activities of daily living? So I try to get a sense of their functional status. The second is I try to get an understanding of whether they understand the risks and benefits of opioids. And I usually find most people know the benefits. Very few people actually know the risks. So that's the second thing I try and do. And the third thing I try to do is get a sense of whether there is evidence of a substance use disorder or addiction. Like, is the use of these opioid medications in fact compromising their life in some way? Are they spending a lot of time trying to get more opioid medications? Is it affecting their judgment or their relationships with family members? You can't do all of this in 15 minutes in a primary care visit, which is why part of what makes this challenging is that sometimes you have to have these conversations over multiple visits. And ultimately, what you have to do is, if you think there are signs of a substance use disorder, you have to get people into treatment. This is a challenge because we don't have enough specialists right now who provide medication-assisted treatment. But it's also challenging because we need to actually shift how we think about who provides medication-assisted treatment, which is that one of my beliefs is that treating substance use disorders should be part of the training that all clinicians get, not just addiction specialists. If you think about it, if you're a dermatologist, you were probably trained during a medical school and residency in how to adjust blood pressure medicines. If you were a neurologist, you were probably still trained in how to adjust someone's insulin for their diabetes. The question is why? Because we have understood that these are basic tools that are needed to treat illnesses that are very, very common, and so every doctor should be trained in those. I think what we're seeing with substance use disorders is that these are becoming so prevalent that it's important for us to ensure that all clinicians are trained in how to approach, diagnose, and treat substance use disorders, because it's hard enough to get someone to treatment. And we should have a no wrong door policy so that whichever provider you actually go to, it's somebody who can help understand whether you have a concern and get you the treatment you need.
Can I add just another quick layer of complexity to this issue? And again, back to rural areas, 85% of the persistently poor areas in this country, counties, are rural. And what you have is a circumstance and situation where you have an economic aspect of this as well. If someone doesn't believe that their tomorrow is going to be any better than their today, they're absolutely looking for something that's going to make them feel like at least maybe there's a chance of that. And so part of what we have to do, not only all of the things we've talked about here today, but we also have to begin focusing on a new economic plan for rural areas so that people do begin to think, geez, my tomorrow could be better than my today. I don't want to necessarily go down this route. And that's another layer of complexity to this issue.
Thank you. That's an important point. We'd like to open up the floor for questioning. I think there's microphones places. So the gentleman right here in the blue shirt, I think someone's going to get a microphone to you. And if you could just tell us your name and if you're affiliated with any group. Oh, this gentleman here, the dark blue, and then we'll go to the light blue.
Good morning. My name is Lincoln Mundy, and I'm a Truth Initiative scholar. So I was born and raised in Farmersville, Texas, and if you couldn't tell by the name, it's definitely a rural community. So my question is that just growing up in that kind of environment, there's an evidence of severe mistrust between community members and government and large organizations. So I was just wanting to hear a little bit more about how the administration has attempted to fill that trust deficit and made sure to provide the necessary treatments to these rural communities. They might not be so trusting of the government.
Excellent question. Do you want to tackle that?
Well, I tell you, in 920 counties that are struggling with economic challenges, we've created in my department a thing called Strike Force, which is designed to try to create and build that trust. We go down into the local area and we don't say, we're from the government, we're here to help, here's what we're going to do for you. We come down with one question: what do you need? How can we help you? Many communities will say, we don't have access to mental health services. And then our response is, well, we will work with you under our community facilities program to get the resources to build a facility, or if that doesn't make sense, we'll work with your local healthcare facility to create a telemedicine opportunity. We'll have a grant or a loan program that can make that happen. We let the community define the problem, and then we help them find the solution. And what we have found with this effort is it's now extended beyond the Department of Agriculture. The administration has a series of promise zone areas where we're doing this across the entire federal government. And what we're seeing is a remarkable acceptance of this approach and pretty good results in terms of creating additional jobs, expanding access to healthcare, improving education, making training opportunities more readily available in these persistently poor areas. This is in neighborhoods and major cities, and it's in rural and tribal areas as well. So that's one strategy that we're embracing.
The other gentleman with the blue shirt, right back there.
Hi, my name is Bob Wales, and I'm a pain medicine specialist. And so I'm at the tip of the spear in terms of this whole issue. And I first want to thank you for a really good overview of this difficult problem. And to highlight some of the issues, and I think Dr. Murphy really brought up some good points. In terms of the perspective, what we're talking about in terms of treatment is after the horse has already left the barn. So ideally, just like you would with diabetes, it's better to talk about prevention. And that still seems to be really underplayed in all these discussions. In diabetes, you don't want to just research insulin to treat the problem after it's there. You'd like to deal with diet and obesity. Likewise, in the opioid epidemic, the problem is that physicians are prescribing too many narcotics, but it's not only from lack of education, it's from lack of alternative resources. The CDC has come out with guidelines. Our specialty organizations have come out with good guidelines, good educational programs. The question I have for you is, how do you address the resources, get the resources to the alternative treatments of pain that are so critical and that would allow doctors in both rural and other areas alternatives to just prescribing only narcotics as the only treatment of pain? And you highlighted some of those, and these are all well known. They're physical therapy, they're cognitive behavioral therapy, they're multidisciplinary pain clinics that you can use to prevent the need to prescribe all these narcotics. Can you comment on that, please?
Sure. So first of all, thank you for the work you do as a pain specialist also. I know it's not an easy field to be in, and we need more people like you, so I appreciate your contributions. The point you make is good, and it's one that we appreciate, which is that prevention is always better than cure. The thing is, that's a common sense thing. People know that, but it's actually not how we have historically operated as a country when it comes to health. If you look at where the majority of our investment as a country has been, it's been on the treatment side, for decades. And so part of the larger issue, even beyond opioids, that we have to take on is how to shift our country to more of a prevention mindset from solely a treatment mindset. But when it comes to this epidemic, the prevention piece is part of the reason why in the campaign that we have launched, the Turn the Tide campaign, we are actually focusing on working with prescribers to help change prescribing practices from the outset so that people are not putting patients inadvertently at risk for developing addiction. The issue around access to non-opioid alternatives is a real one, and it's a common thing I hear as I travel around the country is that people, hospital administrators, doctors, and even patients say, look, we want to use some of this stuff. And sometimes we can get it, and other times we can't. Sometimes it's because it's too expensive. Sometimes it's because it takes too much time. Like if you think about it, writing a prescription for oxycodone for 30 days, it might take a doctor maybe a minute in the clinic. The patient goes and fills it. They might pay a copay once, and then they have a 30-day script. If you recommend physical therapy 3 times a week instead, that's more time, it's more copays, it's more of an investment. And so there are other barriers as well, but the coverage piece is important, which is why it's so important that we enroll people who are eligible for coverage under the ACA. It's why Medicaid expansion is so important, but it's also why it's important that we work with payers, with insurance companies, to ensure they are prioritizing pain treatments that are non-opioid based. And this is, last year, actually, the White House, the Office of National Drug Control Policy in particular, convened payers to talk to them about the importance of expanding coverage to include these alternatives and to ensure that the reimbursement was adequate. Because covering it is not enough. I had a hospital executive in Oklahoma City who told me that they're trying to use IV Tylenol more than using opioids, but it's almost a 10-fold difference in price. And that's really tough for them to absorb. So we have to make it easier to do the right thing. But it's not only the federal government that can work with these payers. What we're finding is that at a state level, Medicaid programs can work with payers. At a city and local level as well, hospital systems, especially larger ones that have market power, can be a force for working with payers. And finally, individual clinicians have much more power than they think. And I say this as a clinician who looked at my colleagues around in 2008 when there was a lot of discussion around healthcare reform and the presidential elections. And I saw all this excitement in the country around the possibility of healthcare reform. But I'd look at my colleagues and I saw pessimism and despondence. And it was because many people in society look at doctors as people who have a lot of power and influence. But strangely, many doctors look at themselves as people who are disempowered, who are beaten down. And they would tell me all the time, nobody wants to listen to what I have to say. They're going to listen to like big pharma companies and hospitals. They're not going to listen to the little guys like us who are on the front lines. But I want to tell you that your voice really does make a difference, especially with elected leaders. I had one member of Congress who once told me, he said, we get a lot of constituent calls. If we get one call from a doctor in a given day, that's written as a notable event. If we get 10 calls from doctors in a given day, that's a full-blown crisis. And it just goes to show like actually how little our profession actually uses their voice to speak up, especially with our elected leaders. But I think we could make a big difference there.
Just to add to that, there's a facility and a personnel issue with your question. And that, I think, challenges government to think of creative ways to use the tools we have and the resources we have in a creative way. For example, potentially making grants and loans to communities somewhat conditioned upon an evaluation of whether or not they have adequate personnel, whether they have adequate facilities. Basically, looking at our AmeriCorps, our student loan forgiveness programs, ways in which we could potentially incent people to think about a career in an area that they wouldn't necessarily think of initially because they're concerned about paying off that student loan, they're concerned about a decent life. Ways in which we can use the government programs to incent and direct folks into this is another way of doing it. And that's one of the reasons why we're now using our housing programs to help drug courts. Nobody would have ever thought of that, except that we were in a drug court and someone said we can't find a place for these people to live.
I think we had a question on this side of the room. The woman back there. Yes, you, the one who's looking around, yes.
Hi, my name's Anita Moose, and I'm a teacher at the Aspen School District. Not an expert in any of these areas, but I do know that in our local valley, we have a treatment facility for men, and only recently did we get one for women, and that we have sober living homes for men, but not for women. And so I'm wondering, do you see that as a trend, or is that just something that we see locally in our valley?
That's interesting. I don't know the national statistics on this, but I can say in most of the places that I've traveled to and most of the treatment centers I've seen, they've been available to both men and women. And there's sometimes considerations for why you may have one versus the other, but most of the ones that I have seen have been integrated. I did also want to mention, you mentioned that you're a teacher, is that right? And you said you probably don't know much about this kind of stuff. I actually want to push back a little bit on that. I think as a teacher, you have a very important role to play in helping us combat this epidemic. A few months ago, I was visiting a town, and an educator was in fact telling me about a pill party that her students had. And for those of you who are not familiar with this, these pill parties are where young people will come together, they'll, at somebody's house, they'll each bring a pill, a bottle of pills from their parents' house. They'll empty them all out into the bowl, mix them up, and then they'll pass them around and each take a handful. And if this sounds like a terrible idea, it is. It's a really bad idea. And the reason she told me this story is because the night after one of these pill parties, she said one of the mothers noticed that her son wasn't coming down for breakfast. And it was getting later and later, so finally she went up to check on him and found him comatose in his bed. Now, fortunately, they were able to call 911, get EMS there, and they were able to revive him. But they also did something else that was very smart, which is they tracked very quickly all the other kids who were at the party, and they found 2 others who were actually comatose in their beds. The reason I bring this up, for you as an educator in particular, is that I think that teachers have an incredibly powerful role they can play in helping young people understand the risks of these medications. Because many of these kids thought that these were benign. You know, like kids, for example, now have gotten the message that smoking is bad for you. They may smoke anyway, right? And there are other reasons why they may do that, to fit in, they think it's cool, whatever it might be. But they've gotten the message that it's bad. Many of our kids have not gotten the message that these pills are in fact dangerous. A lot of them think, well, if a doctor wrote a prescription for it, it's probably safe. So that's why I think actually you do have a very important role that you can play. And it's not just in information, but it's also in helping us build what I think of as an ethic of compassion that we need to treat this problem. You know, we talk a lot about policies that are required, programs that are required, and these are incredibly important as we've discussed. But compassion is really what allows us to stop judging and to start helping. It's what allows us to put our own bias aside and offer people support. And help and support are what so many families need right now as they're dealing with addiction. That's an area where I think you as an educator can be an incredible role model, can help us shape culture as well as getting information to kids.
Well, unfortunately, we've run out of time, but Secretary Vilsack, Dr. Murthy, thank you so much, both of you, for a wonderful discussion.